Yes, good afternoon, everybody. Ya lublю тебя. That's the extent of my Russian. I once had a Russian girlfriend, so that's it. Non-invasive respiratory management of spinal cord, of spinal muscular atrophy for a normal life expectancy. All right, to put things in perspective, when a baby is born floppy, 80% develop normally, about. However, if at 7 months, the other 20% cannot raise their heads or sit by 7 months of age, 70% of those children have central nervous system disorders, but 15% have neuromuscular disease. By far the most common neuromuscular disease of floppy infants is spinal muscular atrophy type 1. So this is a list of the most common neuromuscular diseases of children with floppy infants. Again, spinal muscular atrophy is by far number 1. And all children with spinal muscular atrophy type 1 have paradoxical breathing. I'm getting a mess now. However, 2% of children that appear to have SMA type 1 have a condition known as SMARD type 1, which is an SMA without chromosome 5 abnormalities or without one deficiency. Now, 50% of patients with SMA type 2 also have paradoxical breathing. All infants, all children with paradoxical breathing must be put on sleep, non-invasive ventilation, or their lungs will not grow. They come right to the clinic for a number of issues that we'll talk about. As a simple review, with type 1, all children require non-invasive ventilatory support and access to mechanical insufflation, exsufflation. There are 8 countries that make cough assist type devices. The United States has Respironics makes a cough assist. In England, they have another machine. In Israel, in South Korea, all of these mechanical assisted coughing. They provide mechanical insufflation, exsufflation. They give you a deep breath, and then the pressure drops to -60 centimeters of water.
Professor John, I'm sorry to interrupt. Can you hear me? We have a broken voice now. Can we ask you? Can you hear me? Can we ask you to switch off the camera for a moment, because there is a bad internet connection right now. Only camera. Because we can't hear you. Yes, let's try like that. Can you hear me? No. You turn off the microphone. Can you unmute yourself? We cannot hear you. Can you turn on the microphone?
Children with type 1 neuromuscular disease. And that includes children with spinal muscular atrophy, with congenital myopathies, congenital muscular dystrophy, all children who can never sit independently need access to non-invasive ventilatory support and mechanical insufflation, exsufflation. In particular, all children with paradoxical breathing. Now, paradoxical breathing is where when the stomach comes out, the diaphragm goes down, and the child is inhaling, the chest wall sinks in. That is paradoxical breathing. All children with spinal muscular atrophy type 1 have paradoxical breathing. 50% of children with spinal muscular atrophy type 2 also have paradoxical breathing, and they need sleep non-invasive ventilatory support. The other 50% of children with spinal muscular atrophy type 2 do not have paradoxical breathing. They do not need nighttime ventilation. And sending children, in the United States, children are sent for what they call sleep studies or polysomnograms. This is a completely useless procedure for them because if they have paradoxical breathing, they must use sleep ventilatory support so that the paradoxing goes away. It is reversed so that when the stomach goes out, the chest wall goes out also. So that when the child is inhaling, the chest also expands for the air to enter the upper lungs as well as lower. Now, with children with spinal muscular atrophy type 2 who do not have paradoxical breathing, they usually only need non-invasive ventilatory support and mechanical insufflation exsufflation when they have respiratory tract infections like respiratory syncytial virus or any upper respiratory tract infection. This makes them weaker, their vital capacities go down, their cough flows go down, and they usually need non-invasive ventilatory support and mechanical insufflation exsufflation during those infections to prevent pneumonia and acute respiratory failure. Children with spinal muscular atrophy type 3 who can walk usually need access to mechanical insufflation exsufflation during respiratory tract infections after age 3 and maybe much, much later as teenagers or even adults. So as I mentioned, polysomnographies are useless because all children with paradoxical breathing need non-invasive ventilatory support or their lungs will not grow and they will develop pectus excavatum and funnel-shaped chests. This is a child who now will begin non-invasive ventilatory support during sleep. And look at what happens when you inflate the child's lungs with positive pressure ventilation. This is another spinal muscular atrophy type 1, a child with type 1. And when children cry, they expand their lungs, and that's what has them grow. When children cannot take deep breaths and cry, their lungs do not grow. Now, how do we measure? How do we evaluate these children? Well, number one, we measure their carbon dioxide levels by using end-tidal carbon dioxide or capnography. The carbon dioxide can be measured by putting an electrode on their skin as transcutaneous carbon dioxide. For the end-tidal, the pickup is at the nostrils, as I think you can see. So when the child exhales, it picks up that air, and we can measure the carbon dioxide in the end-tidal sample. Now, with little children, they don't take deep breaths, and this will not be accurate unless you press on their stomachs to increase the exhalation volume so that we get a true end-tidal carbon dioxide. It is rare, though, for these children to have elevated carbon dioxide unless they are given oxygen. When children are inappropriately treated with oxygen, their carbon dioxide levels can get very high and they can stop breathing. We measure oxygen saturation with a small oximeter. This is a very old one. In older children, we measure their cough flows by using a peak flow meter However, with SMA type 1 and 2A, the cough flows are always unmeasurable. They're zero, which is why these children will develop pneumonia and respiratory failure unless they have access to mechanical insufflation, exsufflation. And we measure spirometry. We get a non-digital spirometer. And for many reasons, it's better to have a spirometer that is not digital. And we, and one of the reasons is that when we measure something that we call air stacking or active lung volume recruitment, we have to get consecutive volumes of air. And with digital devices, they usually don't allow you to do consecutive volumes of air. So we add up those volumes and we get a maximum insufflation capacity or the air stacking ability of the child. Many digital devices will not allow that. And I will explain that further later on. So I recommend a non-digital spirometer. Now, there's a website that I will show you that has all the centers I know of in the world that offer non-invasive ventilatory support. And I believe there's one or two from Moscow in there also. So take a look. I will give you that address later on at the end of the talk. So what is non-invasive ventilation? In the West, that's called NIV, non-invasive ventilation. Unfortunately, NIV has become synonymous with continuous positive airway pressure and low-span bi-level positive airway pressure, what we know of as BiPAP. Now, why is this unfortunate? Because continuous positive airway pressure is like breathing with your head out of the window of your car going about 60 miles an hour. It acts as an air splint to keep the airway open so that you can use your respiratory muscles to ventilate the lungs. So this CPAP, continuous positive airway pressure, does not help anybody get deeper breaths unless their muscles are strong. The problem with spinal muscular atrophy is that the muscles are weak. It is not a problem of obstructive apneas during sleep. It is not sleep disordered breathing or central or obstructive apneas. It is not the fact that the brain is not telling you to breathe or the throat is obstructing. That is what we call sleep disordered breathing, which is a combination of central and obstructive apneas. With weak muscles, you need air when you inhale and not air to stop you from exhaling. This is very important. The so-called Epap or expiratory positive airway pressure of BiPAP cannot be turned off. And it is counterproductive. It is bad for many reasons. For one thing, you have to increase the inspiratory pressure by the amount of the expiratory pressure to get the same help for your breathing muscles. This can cause air to go into the stomach, and that can be a big problem. It also decreases venous return to the heart because it increases intrathoracic pressure. The Epap also disrupts sleep and is bad for all sleep parameters for people with neuromuscular disease. Why do they use BiPAP with Epap? Because in the West, in the United States, sleep doctors can make a living doing polysomnographies. So they do polysomnographies on everybody, including these children with neuromuscular disease. Now, when they do polysomnographies on old men who snore and actually have obstructive apneas, that's fine. The patients can benefit from the Epap. But when they do these polysomnograms on patients with muscle weakness, the polysomnogram was never programmed to distinguish central and obstructive apneas from muscle weakness. No, it can be done, but routinely it is not done in the United States. So the patients are treated with inappropriate bi-level positive airway pressure. Now, BiPAP, if used at high settings, what we call high span BiPAP, can be very helpful, but it is never optimal. And in the West, it is never used at very high spans because the sleep doctors do not understand in general that patients need 18 to 20 centimeters of water of pressure support to ideally rest their muscles and provide respiratory support. So NIV, non-invasive ventilation, except in our centers, has never been described to be used for ventilatory support, which is why I call it NVS, non-invasive ventilatory support. Again, in the NVS centers, it is used for ventilatory support. When it is used for ventilatory support, it can be delivered via portable ventilators at NVS settings, at non-invasive ventilatory support settings. What are NVS settings? Well, for volume ventilation, because see, the ventilators or the BiPAP machines, whatever you want to call them, they can deliver air that is set by volume or by pressure. Now, BiPAP is only deliverable by pressure. So you set pressures. You set the pressure of air going in and the pressure of air stopping you from exhaling. That's the Epap, which again is not good. However, other machines, what we call portable ventilators, can deliver air that's set by pressure, like BiPAP, or by volume. Now, there are advantages and disadvantages each way. For older children and adults, it is usually better to set the ventilator by volume. A normal breath for an adult is about 500 or 600 milliliters. I set a range of volume from 800 to 1500 milliliters, and a backup rate that is a normal physiologic respiratory rate of about 12. Now, 800 to 1500 milliliters is a lot more than 600 milliliters. However, the patients learn to take as much of the air as they feel that they need. So the average volume used by my older adolescents and adults is 1100 to 1300 milliliters. That is what they like. This allows them to vary their tidal volumes. And it is physiologically very beneficial to vary your tidal volumes for many reasons. Now, I can also, sometimes when this is used at volumes and the child is sleeping, the air can go into the stomach. And if this is a big problem, and if the child does not have a gastrostomy tube to leave open overnight, to burp out the air, we switch our patients to pressure preset ventilation at 15 to 22 centimeters of water, generally. And again, our goal is to reverse the paradoxical chest wall movement during sleep. So we don't put patients in the hospital to introduce them to NVS, nasal NVS. We don't need to do this in a clinic. We tell the mothers to put them on their nose pieces and on these settings when they are in deep sleep, and to watch their chests. And if the chest is not expanding when the stomach goes out, they are not breathing with the machine, and the settings are a problem. So we let the mothers put their children on the nasal ventilatory support. It does not need to be done by pulmonologists or respiratory therapists. And when the mothers see that when the stomach goes out and the chest goes out, there is no more paradoxing, and their children do not develop chest wall deformities. Now, as I mentioned, high span bilevel positive airway pressure at spans of greater than 15 centimeters of water can also do this. So in other words, if you have an inspiratory PAP of 21 and an expiratory PAP of the minimum, which is 4, you're giving the child 17 centimeters of water of ventilatory support. And that is usually enough to reverse the paradoxing. There are 3 aspects to managing patients with spinal muscular atrophy. There's long-term non-invasive management, but if the patients develop a pneumonia anyway and need to be in critical care, they will get intubated. The most important aspect is then to extubate them even when they are too weak to breathe at all, back to non-invasive ventilatory support and MIE. And I will explain that after a break. Also, older patients with tracheostomy tubes, who really should never have had them placed in the first place, can have their tracheostomy tubes removed. But we don't do it for patients who are ventilator dependent before the age of 12, because they're too young to really understand what we are doing, and they're very frightened. If they are continuously dependent on ventilatory support, we are not going to offer to take out their tracheostomy tubes until they decide they want them out and understand how we're going to do that. So it is very important to understand that no patients with myopathies, muscular dystrophy, or congenital myopathies, no patients with lower motor neuron disease like spinal muscular atrophy, no patients with peripheral nerve disease need tracheostomy tubes for ventilatory support long term. However, patients with upper motor neuron disease, patients with classical amyotrophic lateral sclerosis, some patients with a cerebral palsy and with traumatic brain injury and stroke, these patients' upper airways collapse. And because they collapse, the upper airway is not open enough to get secretions out by using MIE, mechanical insufflation exsufflation. And sometimes they have so much stridor, that kind of sound, excuse me, that they need tracheostomy tubes. Nobody with spinal muscular atrophy, type 1 2, 3, or 4, nobody with any muscular dystrophy or congenital myopathy needs a tracheostomy tube for ventilatory support. They can be managed by NVS. So in 1996, I did not know this. So the older boy here behind Danny is Michael. And Michael, when he was 4 months old, was not breathing very well. He had severe paradoxical breathing. And we put him on nasal NVS. Now, he has no bulbar innervated muscles. He has no throat muscles. And all doctors think that if you have no muscles in your throat, you cannot speak, you cannot swallow food, you need a gastrostomy tube, which he had placed at 4 months of age. Doctors think that you need a tracheostomy tube because you cannot protect your airways. I thought so too in 1996. In 1995, I told his parents that he would need a tracheostomy tube or he would die within 1 year. Mom got pregnant again and had another child who had the same spinal muscular atrophy type 1. At 4 months of age, the second child, who you see here in front, also needed nasal NVS. And he immediately needed it 24 hours a day. Michael needed it 24 hours a day at 7 months of age. But at that time, I didn't tell the mother that Danny would need a tracheostomy tube. I did not say that because Michael didn't have one. Now, you cannot see it here, but these boys have nasogastric tubes for all nutrition since 4 months of age. 4 months of age. Not only did their parents refuse tracheostomy tubes, they also refused gastrostomy tubes. So in 1995, I didn't think they could survive without a tracheostomy tube. And here they are in 2010 with their parents at Yankee Stadium in New York City. And in 2012 and 2018 and now. So Michael now is 25 years of age and Danny is 23 years of age. They do not have tracheostomy tubes, and they still have nasogastric tubes because the parents never agreed to a gastrostomy, but they're ventilated through the nose, their noses. Now, they've never been able to speak, make vowel sounds or consonant sounds. They've never been able to do that. And they have not been able to take any nutrition by mouth since 4 months of age. But they're 25 and 23 years old. They have no muscle movement. They have no throat muscle movement. They have no finger movement. They cannot move their tongues a millimeter or grimace, make a smile, or use their facial muscles at all. However, they can move their eyes enough to use a computer to speak for them and operate environmental controls. And we're trying to get them to use eyeglasses that will be set up so they can operate motorized wheelchairs. And they should be able to do that. Well, in 1995, I also told the parents of this boy that in 1 year, he would be dead without a tracheostomy tube. Now, he is a typical spinal muscular atrophy type 1. These boys were among the most severe SMA type 1. In fact, some people would call them type 0. They're 24-hour vent dependent before about 6 months of age. And Danny, it was at 4 months of age. But they became, Danny became ventilator dependent on nasal ventilatory support without ever going to a hospital. They never went to a hospital to be placed on nasal ventilation. Their mothers did it when they were sleeping at night. And we trained them in our outpatient clinic. They never, I need to repeat that, never hospitalized to be placed on ventilatory support. And in fact, to this day, each one has only been hospitalized once for respiratory problems. And I'll talk about that later on. So this boy is 1 year old with paradoxical breathing, and I placed him on nasal ventilation. There were no CPAP masks or nose pieces on the market at that time. So when they were babies, the two brothers and this patient, we ventilated by using Hudson CPAP prongs that we put through a soft, foamy, sticky and material that is gotten from CPAP masks that are for nasal bridge material. Let me just say that we now have nasal interfaces for infants. So we don't have to use the Hudson CPAP prongs anymore. But I told this boy's parents that he would also be dead within 1 year if he didn't get a tracheostomy tube. So 3 or 4 years later, he was going trick or treat with his brother and sister. And here he is at 16 and a half years of age. I'll tell you about this later on. We had to intubate him at that time for 24 hours because he had a respiratory infection and he and his parents were exhausted using the cough assist around the clock for 2 weeks. But after 24 hours, we extubated him and sent him back home. Today, he is 27 years old. And we have about 100 of these patients on non-invasive ventilatory support with SMA type 1. None in New Jersey have died. And very few have died anywhere from using non-invasive ventilatory support. At this time, when I did this study, we had 72 on it at the mean age of 7 years, and 13 had died at a mean age of 4, but none of them were in New Jersey. So they died probably because of an acute respiratory infection that was not managed the way we manage them. Probably, but you know, the point is that none of our patients here on non-invasive ventilatory support have died. This is a girl who has also been on non-invasive ventilatory support since she was 1 year old, and today she is 26 years old. And I will tell you about her and her respiratory infections later on. This little boy with SMA type 1 was intubated for respiratory failure at 20 days of age. So he was very, very severe, intubated at 20 days of age. He failed 2 extubation attempts in Florida. The reason he failed, one of the reasons was that they extubated him to low span BiPAP instead of NVS. He tried to get transferred up to us but because of COVID-19, our beds were full. So I spoke to the attending doctor down there, an intensivist, and explained to her to not extubate him to oxygen and BiPAP, and I will talk about this later, but to extubate him to high-span BiPAP or NVS from a portable ventilator. She did, and she succeeded. But then I discovered that after successfully extubating him, he did not wean off of continuous NVS, continuous non-invasive ventilatory support, like the patients I just showed you. They are all dependent on nasal ventilation 24 hours a day. And this child was also. And for 2 or 3 months in Florida, they were afraid to discharge the baby to the mother who could be trained in how to take care of her. So they didn't really want to have the mother involved with the baby's care. So they were very late in training her. And then it took them months to have the courage to discharge a baby who is continuously dependent on BiPAP home. Now, none of our patients, at least locally, have ever died from non-invasive ventilatory support. But other hospitals are afraid to discharge these patients using BiPAP. We don't use BiPAP. We use portable ventilators, but it doesn't matter very much. The point is that the baby was ventilated on high-span BiPAP, 25 centimeters of water inspiratory PAP, 4 centimeters of water expiratory PAP, and went home using this around the clock with a mother who understands how to help him and some nursing help. That baby was then treated with Zolgensma, and I also think Spinraza. So these are 2 medications that can convert SMA type 1 children to SMA type 2 or SMA type 3. And this child now has weaned to nighttime nasal ventilatory support. And the child has minimal or no paradoxical breathing anymore. And the child can breathe all day on his own. And you see his big smile. So this child is no longer using daytime ventilatory support. And I am pretty sure it's because of those medications. The medications really work when you give them to very young children. But the point is that this child does not have a tracheostomy tube and will never need one, and should be able to live 25, 30, or even 60 years like my brothers that I showed you with SMA type 1. So how long can NVS be effective? Well, obviously for SMA type 1, we now have more than 10 patients over 20 years of age who are continuously dependent on non-invasive ventilatory support, and even 3 patients over age 25. So obviously for SMA type 1, continuous NVS can be used indefinitely. And these patients have normal blood gases. They do not aspirate any secretions because they are positioned to sit forward in the wheelchair so that they can drool, but the secretions do not enter their airways. And when they sleep at night, their necks are rotated so that the secretions leave their mouths, but they are not aspirated. In Duchenne muscular dystrophy, we now have over 120 or 30 patients on 24-hour non-invasive ventilatory support. many for over 30 years. And we have Duchenne patients now 51 and 58 years of age on continuous non-invasive ventilatory support for over 30 years. Many over 45 years of age. None have tracheostomy tubes. People who had polio in the 1930s, 40s, and 50s, I now have patients who have been on continuous non-invasive ventilatory support since 1954. That's 66 years of continuous non-invasive ventilatory support, and ALS patients who are predominantly lower motor neuron and not so much upper motor neuron. I have patients on continuous NVS for 14 years now. But the majority become upper motor neuron and their airways close. And after about a year of non-invasive ventilatory support, they need tracheostomy tubes to survive. This is a woman who has been on 24-hour non-invasive ventilatory support for 66 years. She uses a mouthpiece like this during the day, and this woman has no movement below the neck, no movement below the neck, but her head works pretty well. She's able to speak well and eat, and for 40 years she has worked as a rehabilitation counselor using her telephone. 66 years of non-invasive ventilatory support, no tracheostomy tube. She uses this lip seal for the air during sleep, like him. He used this for 49 years of non-invasive ventilatory support, 24 hours a day, and he had 0 milliliters of vital capacity. He could not move any air into his lungs on his own. 0. This is an ALS patient, also on 24-hour non-invasive ventilatory support, using his nasal ventilation to exhale and blow out those candles. So, there are 2 types of pulmonary impairments. There's failure of ventilation and failure of oxygenation. Now, failure of ventilation means that your carbon dioxide goes up because you're not getting enough air. Failure of oxygenation happens when you have lung or airways disease. Now, most doctors are only familiar with lung and airways diseases. Pediatric pulmonologists treat asthma, bronchopulmonary dysplasia, and other lung diseases. Adult pulmonologists treat chronic obstructive pulmonary disease. In both cases, patients need oxygen. However, when you have weak muscles, the oxygen is very bad for you because it causes the carbon dioxide to go up a great deal. And it turns off your breathing. Your hypoxic drive to breathe is turned off if you get oxygen. So the carbon dioxide can become very high and patients stop breathing. They develop what we call carbon dioxide narcosis, like narcotics. If a patient with SMA visits a doctor and that doctor puts him on home oxygen therapy, he will be back in respiratory failure sooner than if nothing is done for the patient. I'm going to repeat that. If any patient with neuromuscular disease, spinal muscular atrophy or muscular dystrophy or any, goes to a doctor and that doctor puts him on oxygen in the home, he will be back in respiratory failure, hypercapnic respiratory failure, sooner than if the doctor does nothing for the patient. Also, we studied 700 patients on long-term mechanical ventilation, both with tracheostomy and patients on non-invasive ventilatory support. The patients on continuous non-invasive ventilatory support had the lowest pneumonia and hospitalization rates. They had even lower hospitalization rates than patients with tracheostomy tubes who were not using ventilators. The reasons for this are many. A tracheostomy tube always has bad pathogenic bacteria colonization on the tube. Antibiotics cannot get to those bacteria and kill them. So patients can have recurrent pneumonias that will damage their lungs and kill them eventually. I'm going to repeat this. Patients who have even intact bulbar muscles, patients who can eat and speak and do not have gastrostomy tubes, but who are ventilated through tracheostomy tubes, have significantly more hospitalizations and pneumonias and episodes of respiratory failure than patients using non-invasive ventilatory support 24 hours a day, continuous NVS. Oxygen therapy is not a substitute for non-invasive ventilatory support and mechanical insufflation, exsufflation. Also, oxygen makes the oximeter useless as a gauge of what is going on. Now, normal oxygen saturation is 95% and more. Anyone who does not have lung disease or SMA, if you put an oximeter on your finger, it will never be less than 95% when you are awake. When we are asleep, it goes below 95% in all of us, and it's nothing really to worry about most of the time. However, when we are awake, you can put the oximeter on your finger anytime and it will always be 95 and more, unless you have severe heart disease or respiratory failure. So, if the oxygen saturation is 94%, you must think of three things for a patient with SMA. One, the patient may not be getting enough air. The carbon dioxide may be high, and the patient may need non-invasive ventilatory support, NVS. Two, the patient may have airway secretions that's causing the oxygen saturation to go below 95. If you don't get those secretions out and get the oxygen saturation back to 95 and more, that patient will develop pneumonia, lung collapse, gross atelectasis, and will need to be hospitalized and probably intubated. If you even give that patient a little bit of oxygen, a half a liter or 1 or 2 liters of oxygen at home, that oxygen, that oximeter will stay 95% or more, even though that patient is developing pneumonia and respiratory failure. Oxygen should never be used as a substitute for ventilatory support and airway secretion management. Never be used. Even a small amount of oxygen can make the oximeter useless as a gauge of the health of the lungs and the clear and the state of the airways, how clear the airways are. So the oxygen essentially covers up the fact that you have airway secretions. It is like putting a Band-Aid on a cancer. Giving anybody with SMA type 1, 2, 3, or 4 oxygen is like putting a Band-Aid on a cancer, which will get worse and eventually could kill them. And it gets worse by allowing the carbon dioxide to go up or the secretions to accumulate in the airways until the patient goes into acute respiratory failure and needs to be intubated and may die. This is extremely important. Now, for patients with classical ALS who definitely do not want tracheostomy tubes and who cannot use non-invasive ventilatory support successfully anymore because of closure of the upper airway, most of us feel it is appropriate to give them oxygen and narcotics so they are not short of breath and they die without being short of breath. And I agree with this. However, if a patient wants to live, you never use oxygen as a substitute for ventilation and clearing airway secretions. Pulmonary function testing in America is pulmonary function testing to assess lung disease and airways diseases. It is almost completely useless for patients with spinal muscular atrophy, including all patients with neuromuscular disease. The reason it is useless is because the only thing of value is the vital capacity measurement. But the vital capacity measurement is always done with the patient sitting, never lying down. But ventilatory failure begins during sleep when the patients are lying down. And the vital capacity can be determined in babies as well as in adults. It is wrong to say that the child is too young to get a vital capacity. We measure the vital capacities when they are intubated, when they are trached, and we measure them through a mask covering the nose and the mouth if they're too young to cooperate any other way. That is called the cry vital capacity. It was described in the 1960s. And when the cry vital capacity is 50 milliliters or more in an infant, that infant will not need 24-hour ventilator use. If it is less than 50 milliliters, he will. So the pulmonary function testing also does not test cough flows. It does not test vital capacity in different positions. It does not test lung volume recruitment, which I will explain. It does not test carbon dioxide levels non-invasively, which are more accurate. And sometimes it doesn't even test the oxygen saturation. And it's expensive. It's completely unnecessary. Now, pulmonologists have a tendency to put all children with neuromuscular disease and spinal muscular atrophy on bronchodilators and oxygen. There is no evidence that they are at all beneficial, and bronchodilators can sensitize the heart to sympathetic nervous system stimulation and actually be detrimental when they are not needed. Are bronchodilators ever useful in SMA? Well, many of my patients think that when they are sick, it can help them. Oxygen is never useful unless the patient is intubated or unfortunately has a tracheostomy tube. And even then, they should not need it. But bronchodilators we use only when children are sick. Otherwise, we do not use it routinely. The patients simply need ventilators and MIE, mechanical insufflation exsufflation. So pulmonary function testing is almost completely useless. And in fact, the vital capacity of patients with SMA, including SMA type 1, are always greater when the patients are lying down than when they are seated, because they're breathing mostly with their diaphragms, and there are reasons for this. So I showed you earlier that every clinic should have the ability to measure end-tidal carbon dioxide, oxygen saturation, spirometry, and cough flows. And patients should not be sent for pulmonary function testing. As I mentioned before, polysomnography is completely useless for these children. Frankly, it's also useless for older patients with weak muscles. When they are symptomatic and their vital capacity is decreased, they need nasal, non-invasive ventilatory support. If they are not symptomatic, I don't care what their pulmonary function testing shows. I don't even care what their vital capacity is. And their CO2 can be elevated, can be high. But if the CO2 is not so high that the oxygen saturation goes below 95, the patients are not symptomatic, and the patients are not symptomatic, they do not need nasal ventilatory support unless they have paradoxical breathing. So I'm going to repeat that. If the patient's carbon dioxide is not so high when they're awake for their oxygen saturation to go below 95, and they do not have symptoms from sleep hypoventilation, they do not need sleep non-invasive ventilatory support. Now, when symptoms are questionable, we do measure their sleep, end-tidal carbon dioxide, and oxygen saturation. If the carbon dioxide goes over 50 and their saturation baseline goes down a lot, I think the patient should be symptomatic. And if it's not clear, it's a good idea to let them try nasal non-invasive ventilatory support, nasal CNVS. If it makes them feel better, they will use it. And if not, don't worry about it. Come back in a year and we'll check you again. If it makes them feel better, they will use it, and that includes infants. The amazing thing is that the mothers get their infants on nasal non-invasive ventilatory support for sleep, and after 1 week, those children will not go to sleep unless they are placed on it. They don't want to sleep unless they are placed on it. Why? Because without it, these children develop sweating, perspiration, flushing, redness of their skin, tachypnea. They breathe rapidly and struggle to breathe with paradoxical breathing. These are symptoms of struggling to breathe during sleep. When you put them on sleep non-invasive ventilatory support, those signs and symptoms go away, and the patients can go to sleep faster and sleep better. And even infants less than a year of age understand this, and they will be resistant to going to sleep without the nasal NVS that they know makes them feel better. Why are tracheotomies bad? Because this is a foreign body that is always colonized with pathogenic bacteria, bad bacteria, that cannot be eliminated by antibiotics and that continue to fall into the lungs. And anybody with a tracheostomy tube has as much bad pathogenic bacteria in their lungs as anybody with acute pneumonia. Up to 65% of patients develop tracheal stenosis. Their airways get severely damaged and closed. And you can see here that below the tracheostomy tube, the airway is closing. That is tracheal stenosis. As I mentioned, these patients have as much bad bacteria in their lungs as patients with acute pneumonia. Also, patients on tracheostomy ventilation always want more air, and their carbon dioxide levels go down. As their carbon dioxide levels go down, they become more dependent on the ventilator. So if you disconnect them, they cannot breathe because their brains are now used to hyperventilation and they have low carbon dioxide in their blood. Now, when their carbon dioxide is low and you take them off the ventilator, it is even more difficult for them to breathe than if their carbon dioxide is normal. When we take the tracheostomy tubes out of tracheostomized patients whose carbon dioxide levels are low and they're continuously ventilator dependent, after removing their tracheostomy tubes and placing them on CNVS, continuous non-invasive positive pressure ventilatory support, their carbon dioxides come up to normal and their vital capacities go up. If the vital capacity gets to 250 milliliters of air, which is only 5% of normal, if it only gets to 250, those patients will wean off of CNVS. They won't need to be dependent on continuous non-invasive ventilatory support 24 hours a day. They will develop what we call ventilator-free breathing ability. Only patients with less than 250 milliliters of vital capacity may not develop ventilator-free breathing ability unless they learn how to frog breathe. Frog breathe is called Vesopharyngeal breathing, and I need to demonstrate it for you. I am wearing a tie with a big frog on it. You can look up glossopharyngeal breathing, frog breathing, on the internet and practice it. I will talk about that in a minute. But also, the tracheostomy ventilation causes the diaphragm to atrophy. In as little as 18 hours of being intubated and on a vent, the diaphragm atrophies, gets weaker. And the patients with tracheostomy tubes die because of arrhythmias, hemorrhage, what we call fistula, and many, many other reasons. The majority of patients with neuromuscular diseases die because of tracheostomy ventilation, not directly because of the disease. This is amazing, but it's true. 4 out of 5 patients with amyotrophic lateral sclerosis on tracheostomy ventilation die because of the tracheostomy tubes. With SMA, the majority of children on tracheostomy ventilation die because of the tracheostomy tubes. The same is true for Duchenne muscular dystrophy. And there are many reasons for this, as I'm pointing out here. So this study on ALS, 4 out of 5 patients died because of the tracheostomy tube. In Duchenne, 50%, more than 50%, the majority died because of the tracheostomy tube. Not only that, but until 1993, when Dr. Ishikawa learned non-invasive management of patients with Duchenne, the patients were not treated and they died at 18 years of age. Excuse me. From 1983 to 1993, all of the patients got trached and they died at the average age of 29. Since 1993, when she learned what we are doing, none of her patients have gotten tracheostomy tubes, and they live an extra 10 years with average survival to 39 years of age. I am positive that patients with SMA will live much longer, like our ALS and Duchenne patients, when they are only treated non-invasively and not with tracheostomy tubes. But for SMA type 1, this is not easy, and I will have to explain it more. There are 3 respiratory muscles that we must consider: inspiratory for breathing, expiratory for coughing, and the bulbar innervated or throat muscles to protect the airways and to cough. When the vital capacity goes below 40%, cough flows become ineffective. Cough flows under 270 liters a minute become increasingly ineffective, and the risk of pneumonia goes up. Our treatment goals are to optimize chest wall elasticity and lung growth and lung volumes. We do this by lung volume recruitment. We also want to optimize cough flows to make them effective and to maintain normal ventilation. Now, air stacking is active lung volume recruitment. The patients take a volume of air from a ventilator or a manual resuscitator, maybe 1,000 milliliters, and they hold it with their glottis. Then they get another 1,000 and another 1,000, and now they have 3,000 milliliters of air, which they blow through the spirometer. That we call the maximum insufflation capacity. This can also be done through the nose for patients on nasal ventilation, and air stacking can also be done for patients using oral nasal interfaces. You can see photos of this on our website and also in my books and articles, which I'll talk about. So this is active lung volume recruitment or air stacking. Now, passive lung volume recruitment can be done by using MIE, like a cough assist. By the way, glossopharyngeal breathing is using the tongue to piston boluses of air into the lungs until you cannot hold any more. Many patients can get to their maximum insufflation capacities, which is their air stacking maximum, by glossopharyngeal breathing, as well as by air stacking with a manual resuscitator. So for patients with SMA type 2 and 3, they can often glossopharyngeal breathe or frog breathe to get deep breaths. Patients with SMA type 1 and type 2A usually cannot frog breathe. Usually, almost never are they able to frog breathe because their tongues are too weak. This is actually a patient whose vital capacity went to 0, and the frog breathing ability in the middle allowed them to get free breathing off their ventilators until they were about 42 years of age, when that also became ineffective. However, they could air stack to 1.6 liters of air, even at the age of 47 and 48. So sometimes you can air stack much higher than you can frog breathe, and your vital capacity can be 0, and you can still do this effectively. We actually have a patient with 0 milliliters of vital capacity who was sleeping, and he awoke to discover that his respirator was no longer working, and he was frog breathing. If it weren't for the frog breathing, he would have died. But people can use frog breathing for ventilator-free breathing from their respirators. So again, you can air stack through the nose, and then after you hold consecutive volumes of air, like 1 liter times 2 or 1 liter times 3, you blow that air into the spirometer, and that's your maximum insufflation capacity or your air stacking ability. This is a woman with 900 milliliters of vital capacity who is able to frog breathe to almost 3 liters of air. This allows her to speak loud and to cough effectively without asking anybody for help. And this is very useful for sleep because she doesn't want to have to disturb other people to help her cough. But she's able to go from 900 milliliters to 3,000 and be able to cough effectively because of the deep breath she gets by frog breathing. A patient with 0 vital capacity who's able to frog breathe all day long and not have to use his ventilator because of it. However, this can be effective for SMA type 2 when they're very old and SMA type 3, but it is not effective for SMA 1 and type 2A. Cough flows must clear the secretions because a mucus plug can cause pneumonia and the lung to collapse very quickly, like this. And if you suction, you never get the left main stem bronchus. Less than 90% of the time does any suction catheter, even a suction catheter through a tracheostomy tube or a translaryngeal tube, will not go into the left lungs. So over 80% of pneumonias are in the left lung. 90% of the deaths in SMA children occur because of episodes of respiratory failure triggered by chest colds. To get a deep breath, to cough, you first need a deep breath. The average cough is 4 times greater than the average breath. So for an adolescent or an adult, a normal cough volume is 2.3 thousand milliliters of air. If the vital capacity is only 1 liter of air, you may have a normal carbon dioxide, but not be able to cough effectively. And when you cannot cough effectively, you will get pneumonia from any respiratory tract infection, and you will go into respiratory failure. So if you can air stack, the first thing you need is a deep breath by air stacking. If you cannot air stack, MIE, the insufflation, inflate your lungs to over 2 liters, and then you go to the negative pressure on MIE, or you use your abdominal muscles and you open your glottis and you cough. So you need inspiratory muscles to get a deep breath. You need expiratory muscles to generate thoraco-abdominal pressure. And you need a glottis to hold the pressure. Now, my patients with 0 vital capacity, with 0 milliliters of vital capacity, they have no inspiratory and no expiratory muscles, but they almost never have any problems because they depend on the cough assist to give them deep breaths and generate negative pressure. However, we cannot substitute for their glottis. But that's not a big problem because if the airway is open, the MIE will generate adequate flows to bring the secretions up and prevent pneumonia most of the time. So we also teach the patient that by air stacking and pressing on their stomachs, that their assisted cough flows go up and become effective. But again, to do this, you need the deep breath, and air stacking can be important. And when you do this, the cough flows become more effective. And some patients don't need the cough assist because they have a lot of help at home and generate good cough flows by air stacking and the abdominal thrust. If there's any one image that I'm asked to show why none of my patients need tracheostomy tubes, except for ALS, it is this image, because my patients can get effective cough flows without a suctioning them or a tracheostomy tube. Now, this is Respironics Cough Assist, and it's not used correctly because it's usually used at 40 centimeters of water or less. That's because in 1993, I wrote 3 review articles saying that this machine was like the former Coughlator that was on the market from 1953 to 1967. I convinced Mr. Emerson to make this device in 1988, and we started using it immediately in critical care. However, I said that this machine was like the old one in that it goes to 40, and it should be used at 40. However, the Coughlator was calibrated in millimeters of mercury, and 40 millimeters of mercury is 54.1 centimeters of water. So because I said it should be used at 40 centimeters of water, it's been used wrongly ever since it's been on the market. This machine, except for ALS and airway closure and stridor, this machine should never be used at less than 40 to 60 centimeters of water pressure through the upper airway and 60 to 70 centimeters of water pressure through a tracheostomy or translaryngeal tube, an intubation tube. Now, this is a little Japanese patient whose tracheostomy tube is being removed. And Dr. Ishikawa is using the cough assist here to clear secretions after removing the tracheostomy tube. Again, it needs to be used at 50 to 60 centimeters of water through the upper airway, through a mouthpiece, an oral nasal interface. And it's even been used through a nasal interface, amazingly. But when used through an intubation tube or a trach tube, it needs to be used at 50 to 60 centimeters of water pressure. Using it for a baby, it's helpful to use the cough track so that the baby can trigger the machine. Otherwise, you have to time the insufflation with the stomach going out. That is with the baby's inspiration. And you have to time the exsufflation with the stomach going in, the baby's exhalation. So you time the MIE to the baby's breathing, or you use the cough track on the E70 Respironics Cough Assist. The last goal is to maintain normal ventilation, and in a minute we'll take a break. But I want to tell you that, again, the symptoms in small children are perspiration, flushing, tachypnea, and paradoxical breathing. Symptoms in older children and adults are fatigue, sleepiness, decreased appetite, depression, and impaired concentration. So the indications for NVS are paradoxical breathing in small children and symptoms of hypoventilation in older patients. How do you begin it? You can start at a pressure preset of 15 and increase to 18 to 20 centimeters of water pressure If you can use a portable ventilator, you don't give any expiratory pressure. If not, you set the BiPAP to the minimum, which is 3 or 4 centimeters of water. And you tell the mother to see that the paradoxing is reversed during sleep. For older patients, if I'm not sure if they're symptomatic, I do a sleep, oxygen saturation, and end-tidal CO2 monitoring. And if the carbon dioxide's around 50 or so, I ask the patients to try nasal NVS for sleep. I put them on 700 to 1,500 milliliters of volume or pressure control of 18 to 20 centimeters of water with a physiologic backup rate, 12 for adults, maybe 25 or 30 for infants. As patients weaken, they need daytime aid, and when they extend sleep nasal ventilation in the morning, we put them on mouthpiece ventilation for SMA 2 through 4. Or we switch to a nasal prongs interface for daytime support and let them use some sort of mask for sleep ventilation. If they don't feel better using nasal ventilation, we check them again in 3 to 12 months. Their diaphragms are like this weak horse. If you don't rest them, they collapse. The ventilator is like a pickup truck. You use it at night, and then the patient's blood gas is normalized during the day, and they have more energy. I recommend against using BiPAP, but if you have no choice, it's definitely better than nothing. But use it at pressure support of at least 17 centimeters of water. So IPAP 21, EPAP 4 for 17 centimeters of water pressure. An LTV or a Newport or a breezy ventilator from England, or you know, a portable ventilator where you can shut off the EPAP is best. Now for SMA type 1, we used this Hudson nasal prong system, but now there are small interfaces. Notice here that this is a flexible metal support arm holding a mouthpiece. These are about $40, and they're also microphone holders to hold the mouthpiece near the mouth for the patient to grab. Mouthpiece ventilation was described in 1953. Dr. Affeldt in Los Angeles said, you hang the mouthpiece by the patients and they grip it with their lips when they want it, and when they don't want it, they let it go. It is just too simple. So they took patients out of iron lungs in 1953, and patients that I met never got tracheostomy tubes. Most of them used the Trilogy ventilator. The Trilogy has a few interesting things. One is called a KISS trigger. So you can set the rate to 0 so that air is not blowing in the patient's face. The patient will get the air only when they touch the mouthpiece. You should be aware of what a Pneumo Belt is. An intermittent abdominal pressure ventilator. An intermittent abdominal pressure ventilator has an air sac inside a corset that's worn under the clothing of the patient. The ventilator is on the back of the wheelchair, and it pumps air into the air sac, not into the nose, the mouth, or the throat, or the neck of the patient. It presses on the abdomen that moves the diaphragm and ventilates the lungs. Any portable ventilator can operate these Pneumo Belts for most patients. It is made by the Dima company in Italy, and I believe it's on the market in Europe. Now, again, we give our patients oximeters that can cost $7. And we tell them to keep their saturation normal without getting any oxygen, especially when they are sick, and only when they are awake. And if it goes below 95%, they're not getting enough air, they have mucus that they are not clearing, or they have pneumonia, and they need to go to the hospital if the saturation baseline stays low. Now, I told you, you do not ever use oxygen unless the patient wants to die. Sedative medications are almost as dangerous as the oxygen. Okay, so I think we should take a 10-minute break here. And I remember now that I gave an English version of my talk, but I have not been using it. So I will dig that up if I can and try to stick with that to help the translators. I hope everything has gone well. And it's, I've got, well, it's 10:53 here. It's 7 minutes before the hour. Would 10 minutes be okay? Or do you want more? I can answer questions during this time.
И мы вернулись в эфир. Теперь мы вместе с Джоном Бахом готовы отвечать на вопросы. Теперь мы наконец-то его можем видеть. И первый вопрос, который я позволю себе адресовать перед тем, как перейду к вашим вопросам, вы, кстати, можете их писать в чат, и мы их ждем. Это тема глоссофарингеального дыхания и ручные техники откашливания. Мы попросим профессора Баха нам их показать.
Okay, so I will demonstrate frog breathing. Again, SMA1 and SMA2 are not going to be able to do this. Some of the SMA2s would be able to. And SMA3, people don't usually get into trouble until much later in life, except for respiratory tract infections, where they may need MIE. So if you relax your diaphragm and go down to what we call the functional residual capacity, and then take 15 or 20 frog breaths, gulps we call it, and then relax again, the air that you get, you will have gotten by frog breathing, the air that you exhale. So I'm going to do that. So I got that air by frog breathing. So if I get hit by a truck and my neck is broken, and I cannot breathe, I have no muscles below my neck at all, nobody would have to intubate me, nobody, because I could literally frog breathe all day long. And then at night, I could use nasal ventilatory support. And nobody would ever need to intubate me, and I wouldn't permit it because I can ventilate my lungs by frog breathing. And of course, I could use a Pneumo Belt or a mouthpiece. Now, another way to do frog breathing is to take as deep a breath as you can, to go to your inspiratory capacity, and then frog breathe on top of that. So I will demonstrate that also. And you frog breathe until you can't hold any more air. Okay, so I can add air to my vital capacity or my inspiratory capacity by frog breathing. And everybody should know this. Everybody should learn this, even if you don't have SMA, because well, in the United States, you could be shot in the neck, or you could have a motorcycle or a motor vehicle accident and not have any muscles below your neck. Now, if you're unconscious, you cannot do it. But if you're conscious and you do not know how to frog breathe, you will be very sorry. You will not be able to breathe, and that will be terrible, okay? Of course, it's terrible to be shot in the neck too, but at least you'll be able to breathe. So you want to practice frog breathing? Do you have another question or a question?
К нам сейчас присоединилась еще Елена Юрьевна Сапега, вы ее видите на экране. И вот со мной рядом сидит Александр Левантин, наш следующий спикер и доктор-реаниматолог. Ну, собственно говоря, мы сейчас будем задавать вопросы доктору Баху, которого вы не будете видеть, но будете слышать. Вопрос следующий. Как технически провести измерение жизненной емкости легких и эффективности кашля у ребенка, который не может удержать мундштук?
No, it's really very simple. No, it's very simple. We have the baby breathe through a mask that covers the nose and the mouth. Now, when these babies with SMA type 1, they're very weak, and every breath is the maximum they can take. And we take the largest volume that they exhale. So they may have 50, 80, 60 milliliter breaths. Their inspiratory capacity or their vital capacity is 80. It's really simple. It's called the cry vital capacity. When babies cry, they take a deep breath. And the deepest breath they take and exhale through the mask is their cry vital capacity. Also, when you have them breathe through a mask, they're taking as deep a breath as they can take because the carbon dioxide can be building up because of the dead space. So they are taking their deepest breaths like anybody whose vital capacity we are measuring. When the patient is on a ventilator who is intubated, we simply turn off the ventilator, put on CPAP mode, and see how much air the child is exhaling into the ventilator. The ventilator tells us the volume of air that the child is exhaling into the machine. That is the vital capacity. When it's 50 milliliters or more, the child will wean from continuous ventilatory support. Now, you ask about cough flows. That's very different. You cannot get accurate cough flows in SMA 1 and 2 are always 0 with SMA 2A. When you have paradoxical breathing, the cough flows are essentially 0. They're ineffective. But older patients who can cough through a peak flow meter, it's no problem.
Спасибо. Еще один вопрос. У нас сейчас ребенок несколько месяцев, там 10 месяцев ребенку в искусственной коме. У нас была пневмония аспирационная. Мы начали лечение спинразой, но случилась брадикардия и остановка дыхания. Ее вводили на 5 дней в кому, чтобы защитить мозг. Поставили трахеостому и подключили к искусственной вентиляции легких. Попытки самостоятельного дыхания присутствуют. Ее сейчас пытаются вывести из этого состояния, но опыта у врачей с такими детьми нет. Вот что бы вы порекомендовали, что можно сделать в такой ситуации?
Well, this is very unfortunate because when babies with SMA type 1 get trached, they never wean from the ventilator because the trach tube makes them much more dependent on the ventilator because of hyperventilation, because of low CO2, because of mucus and caused by the tube, because of many, many reasons. The babies who get trached never wean from the ventilator unless they are strong SMA type 2. And we have never removed the trach tube of a child with SMA 1 who is less than 12 years old. Now, can it be done? In theory, yes, because we have always been able to extubate children with SMA type 1 without traching them. So why can't the child be intubated, the tube removed and the skin closed, and then extubate the child to non-invasive ventilation? Now, in theory, this should work, but nobody has ever done it. And if anybody does do it, I will see that it gets published because I think it's a very interesting and important thing. But it has never been done. So, unfortunately, when children with SMA type 1 or 2A get trach tubes, with SMA type 1, they never wean off of the trach because the trach makes them more dependent on the ventilator. So that's not good news, I'm sorry, but the key is to avoid the trach tube in the first place.
Спасибо. И вот еще один вопрос. Во время пандемии COVID-19 мы все слышали, что положение лежа на животе положительно сказывается на дыхательной функции. Можно ли сказать, что для пациентов с астмой тоже полезно спать на животе с точки зрения дыхания, если человек спит, например, без вентиляции?
No. No. It's totally different problem. With COVID-19, it's an oxygenation problem. With SMA, it's muscle weakness. And if you lie on the stomach, the diaphragm can't work as well. And patients don't breathe easier with SMA, lying on their stomachs. The vital capacity would go down. But you can measure the vital capacity in all these different positions, and you can actually see.
Спасибо. И еще вот я вижу вопрос.
Yeah.
Как вы подбираете назальный
Okay,
интерфейс для пациентов, требующих неинвазивной вентиляции? Да.
No, one more question, that's fine.
Мне повторить вопрос? Да. Как вы подбираете назальный интерфейс для пациентов, требующих неинвазивной вентиляции легких? Как выбрать, чем использовать? Маску, мундштук, что-нибудь еще? Как подобрать?
Well, no. Look, there are many companies that make these interfaces in Australia and United States. You know, the Respironics company has interfaces for everybody, but so does ResMed, so do other companies. I don't know if you have difficulty importing them. If you do, then I don't know what to do. I got this, 1 second. Yes, hello. I'm doing a webinar. Can you call me in 1 hour? Just call me in 1 hour, okay? Okay, sure, thank you, bye. Yeah, I'm sorry. You need to contact these companies, and maybe you have to buy them yourselves, but they are available. Now, the thing you need to understand is that there are two categories. There are two. Both. No. See, look, SMA type 1 and 2A cannot use mouthpieces. They have to use nasal. You almost never need an oral nasal, but they do need nasal. So now there are nasal prongs, there are nasal pillows, and there are nasal masks. If you use it 24 hours a day, you need to alternate. You need two nasal interfaces. You need one that's nasal prongs or nasal pillows, and one that can be a gel mask for overnight. If you only use nasal half the day, you can use a mouthpiece during the day. Some people use an oral nasal mask half the day, you see? So if you use it 24 hours a day, you need two. And there are, how do you choose them? See, we have home care companies that have these interfaces, and they offer them to the patients, and the patients try them, and they fit them, and they use them. So our therapists have many different interfaces, and they offer them to the patients, and the patients use the ones that they're comfortable with and that don't leak. You know, it's very important to understand that there are two classes of interfaces. There are vented interfaces and non-vented interfaces. This is very important. For people using BiPAP, the ventilator circuit is what we call a passive circuit. It has no exhalation valve. So the interface must be a vented interface. It has holes in it, so that when you exhale, the air goes out the holes. If you use what I use, which is a portable ventilator with an active ventilator circuit, that's a circuit with an exhalation valve, you must use a non-vented interface, whether it's mouth, nose, or mouth and nose. It's got to be non-vented, which means that it has no holes, or if it has holes, they're covered by tape. You cannot use a vented interface on a active circuit or a non-vented interface on a passive circuit. You cannot. So you must understand what you're doing here. Again, a BiPAP, you need vented interfaces, and non-invasive ventilatory support without Epap, you need non-vented interfaces that you can make by simply putting tape over the holes in the nose piece. This is very important.
Спасибо большое, Елена Юрьевна. Я знаю, что у вас есть несколько вопросов, которые нужно задать обязательно профессору Баху из российской нашей практики. Я бы вам хотела слово передать с вопросами.
Okay, so, I need to talk to you about extubation, So why don't we do that for a half hour, then I'll answer more questions.
Да.
Okay, let me try to share the screen again.
Да, хорошо, давайте так сделаем. Елена Юрьевна, да, так сделаем? Да, тогда мы попросим доктора Баха включить снова демонстрацию экрана, чтобы мы видели продолжение презентации.
Yeah, this is very important. Okay, do you see it?
No.
Okay.
We can see it.
All right, so I've got to share screen. All right, so now, you can see it now?
Not yet.
No?
No?
Well, I clicked on share screen. I'll do it again. Share, oh, okay, there.
Okay,
all right.
Now we try to, yes, now we see the presentation now.
Okay, right. Oh boy, I have to advance it. Boy. That little boy that I showed you with SMA type 1 is a very interesting story. He looks so good, but he was intubated when he was 20 days old, very severe. And now he's getting stronger because of medication. But the doctors did not know what to do with him because he was 24-hour dependent on BiPAP. Okay, so extubation. Now, the usual criteria for extubating people is that the doctors think they should be strong enough to breathe, to tolerate low pressure support without being tired, and to have minimal secretions and be able to have an adequate cough. Now that, of course, is ridiculous for patients, for small children with SMA. The usual way of extubating these children is to leave them on oxygen and extubate them to NIV, which is not ventilatory support. And they fail, and the doctors think they need to be trached. They don't need to be trached. They need to be extubated to non-invasive ventilatory support settings, good non-invasive NVS settings. Can you use BiPAP? Yes, but you need to use settings of about 25 and 4. That is an IPAP of 25, an EPAP of 4 for pressure control, pressure support of 21. And the lungs must be healthy, and the baby must be properly prepared. Whether it's a baby or an adult, the preparation is the key, is the most important thing. So, number one, the MIE must be used through the tube. For small children, it has to be used at 70 centimeters of water pressure because the tubes are very narrow and the flow through them is cut very low. So you try to use it at 70 centimeters of water pressure. You use it every hour until the oxygen saturation becomes normal without getting oxygen. That's 95% or more in room air. Also, antibiotics can be helpful. The baby or the small child or the adult needs to be afebrile, no fever, have a normal white blood count. The CO2 should be 40 millimeters of mercury or less. The CO2 must be normal or even low. And the oxygen saturation must be normal without the patient getting any oxygen. Now, to get the CO2 normal, you need to give full ventilatory support through the tube, but at respiratory rates that are physiologic. You don't want to give small volumes and rapid rates. Very often, critical care doctors will give minimum volumes and rates of 30 or 40 or 50. This just causes the lungs to get small. This is not healthy for the lungs. You give normal tidal volumes, normal rates, and full ventilatory support to rest the muscles and get the CO2 to 40 or less. Then the patient must be fully alert and cooperative, receiving no oxygen, no sedative medications, and the chest x-rays should be clearing or cleared. Any CT scan should be improving. This is a young woman with SMA type 2. Now, when she was 3 years old, she was transferred to us to be extubated because she failed extubation attempts at a local hospital. She failed 2 because they left her with oxygen and BiPAP. So she got transferred to us, and we extubated her to non-invasive ventilatory support and MIE, the cough assist. One of the things that is necessary for this is to have a commitment by the family to spend 24 to 36 hours with her after the extubation. This is so that every time the oxygen saturation goes less than 95, they will use the MIE on her to get the saturation back to normal and get the mucus out. Being intubated causes airway mucus. And it takes a few days for the secretions to decrease. So many patients need the cough assist every hour, even every 20 minutes for the first day or two after extubation. You cannot rely on the nurses and therapists to do this. They are too busy. Also, the family must learn how to use it. It serves no purpose to not involve them. They must do this after the extubation. They must be involved in the critical care unit. To do the cough assist after every 20 or 30 minutes, whenever the saturation becomes less than 95% because of mucus. This is very important. The saturation must stay 95 or more when the patient is awake. And if it's less than 95, you check the ventilator, see that the patient is getting all the air. The positive inspiratory pressures are about 20 centimeters of water. Otherwise, the air is leaking if it's too low. And if it's that way, you use the cough assist. And for SMA type, the sound is breaking up? Oh, interesting. Right. Oh, it's funny, huh? Okay, so we prepare the patient for extubation, whether it's a baby or an adult, by getting the saturation normal, which is 95 or more. Yeah. It must be 95% or more in room air with getting no oxygen. And then we extubate the patient to non-invasive ventilatory support. I'm getting a message here, closing some applications. Yeah, I hear it's somewhat of a problem. Uh-oh. Can you hear me now? Yeah, so you need to talk also because I get the idea when I hear you.
Yeah, should we again?
It might get better on its own, you know. It might get better.
Okay, so could I don't know. Could John? Can we try that? You will again come out of the Zoom and coming back. Let's try this because the sound is
yes,
really
we can do that, but I think it's getting better on its own.
Yes. Okay. Let's
so.
try. Okay.
You are sounding clearer to me. No, you're getting better now.
Окей. Елена Юрьевна, можно мы вас попросим выключить камеру на всякий случай? Вдруг это с нашей стороны помехи.
Okay, let me cut out and I'll come back in.
John, can we ask you, you can try to speak more slowly, so probably it will be heard by us clearly, so Daria, even with the technical problem, can, yes. Let's try like that.
Can you hear me or not? Can you hear me?
Yes, we can hear you.
Yeah, it's getting better now.
Yes,
oh,
let's continue.
I know, you went back to the beginning. I'm not sure. Oh, well. All right. Yeah. Oh, now this is hardly advancing here. All right. You hear me? Yeah, you're right. I hear it too very well. Okay, but unfortunately, it went back to the beginning of the file. All right, so let me talk about the extubation of the babies. Now, this job here, see, this was amazing because, do you hear me? All right. So this baby was intubated at 20 days, and they finally extubated him to non-invasive ventilatory support at 4 or 5 months because they did not extubate him properly before that. But then, after he was extubated and continuously NVS dependent, really? I hear you well. No, it's really good right now. Yeah, you can't predict these things, you know. Yeah. All right. Well, I wanted to get through these slides and then I can try to answer the questions, you know. Okay. So now this woman, we extubated her when she was 3, but then she didn't come back for 16 years. She only used her ventilator and cough assist when she had respiratory infections, and did not use it any other time until she was 29. When she was 29, she got a pneumonia and was intubated again, was unweanable, and was transferred to us for us to extubate her again without a tracheostomy. However, you could see her face is very long, and she could only be ventilated with a mask covering the nose and mouth. Because if we ventilated through the nose, all the air leaked out of the mouth, and she could not close her lips to grab a mouthpiece well. So we got an interface that's called a new mask, which seals the lips and the foam covers the nose. And we were able to extubate her to this. And then we transferred her back to her oronasal interface for sleep. Now, the problem was that it took her a few weeks to wean, and she could not use a mouthpiece or a nose piece during the day. The only thing she could use was a Pneumo Belt. And the Pneumo Belt was the only thing that could ventilate her without her wearing a mask covering the nose and mouth. And since she was a teacher, she had to communicate with the students. So she could not wear anything covering the nose and the mouth during the day. Now, this is an older patient. We're using the cough assist to clear her secretions so that we could actually extubate her. This is the same girl after we discharged her and she went back to teach school. Now, this girl with SMA type 1 was intubated every year until she was 9 years old. Then when she was 12 years old, she was intubated again for pneumonia and respiratory failure. She was not weanable at that time. So I stood, when she was ready to be extubated, I stood at the end of the bed and told her mother to extubate her. Now, her mother had been putting her on nasal ventilation since she was 1 year old. Her mother had been using the cough assist on her every day since she was 1 year old. So I told the mother to take the air out of the cuff and pull the tube out, and then put her on nasal ventilation. When critical care doctors say they can't extubate unweanable people, you can tell them that I have the mothers of these kids doing it. Literally, I let her mother extubate her in our critical care unit, and I videoed it. So that was when she was 12 years old. Today, she's 26. She has not been hospitalized in 14 years now. So she had many pneumonias and intubations until she was 9, then one when she was 12, and nothing for the last 14 years because she cooperates beautifully with the cough assist and uses her nasal ventilation day and night. Now, these two brothers were not hospitalized before they became dependent on nasal CNVS. One was hospitalized for pneumonia at 8 years of age, the other at 12 years of age. They were intubated for more than a week, but then when they were ready to be extubated, we extubated them back to non-invasive, to the nasal ventilation. One is 25 years old, the other is 23. So they've had 2 respiratory hospitalizations in 48 years. If they had tracheostomy tubes, they would likely not be alive today. And this boy is very interesting because he was intubated 10 times before the age of 4.5. 3 times he was transferred to us from New York City hospitals so that we could extubate him without a tracheostomy tube. But 10 intubations, including 3 that were not necessary, to the age of 4.5. Then, when he was 16.5, I showed you him using nasal ventilation. He was intubated again. Now, what happened was he had a bad respiratory infection, and he and his parents were using the cough assist around the clock every 20 to 30 minutes. He and his parents were exhausted. They were doing that for 2 weeks. So we put him in the hospital and intubated him, and he slept for 24 hours. And his parents slept. We extubated him, sent him back home the next morning, and he was fine. The respiratory infections actually clear faster when the patients are intubated than when they're not, because you can struggle with the cough assist and helping people cough for weeks before you get better if you are not intubated. But if you are intubated and the doctors learn how to extubate you to non-invasive support like our mothers do, you never have to worry about them getting a tracheostomy tube. So in 2010, we reported 157 unweanable intubated patients who we extubated, all except 2 ALS patients, without any of them getting tracheostomy tubes except those 2 patients. And they had ALS, muscular dystrophy, old people too weak to breathe, what we call critical care neuromyopathies, other muscular dystrophies, myasthenia gravis, post-polio, spinal muscular atrophy, spinal cord injury, and other neuromuscular disease. Then we reported 100 more such patients, 98 more, and again, only 1 patient got trached because of cardiovascular instability. All the other patients we extubated without tracheostomy tubes. Now, decannulation is more difficult to talk about with SMA type 1 or 2. I told you it is theoretically possible, but nobody's ever done it, to intubate a patient, take the trach out, close the airway, and then extubate to non-invasive support the way we normally do. Older patients, even when they're 24-hour vent dependent, we extubate them to non-invasive ventilatory support. We decannulate them. We take their trach tubes out. This is a 29-year-old with SMA type 2. She is from California. In November of 2018, when Santa Barbara was burning because of the forest fires, she was intubated and trached for pneumonia. She had never used a ventilator before that. She woke up with the trach tube and was disgusted. She and her family raised $80,000 to find somebody to remove the tube, even though she was 24-hour vent dependent because of the tube. They spent $40,000 to fly to New Jersey. And when we took the tube out on Thursday afternoon, she had stridor. She could not, the upper airway was closed, and we had to put the trach tube back in. This was because of edema, because of swelling. We put her on a glucocorticoid called Decadron, and then we took the tube out the next morning too, Friday morning. Now, when we took the tube out on Thursday, when she arrived, her cough assist flows, her cough flows on the cough assist were 110. Very ineffective. And she had the stridor, we had to put the trach tube back in. The next morning when we took the trach tube out, her cough assist flows were 125. She still had stridor, and we had to put the trach tube back. After 4 days of Decadron, we took the trach tube out. She had no stridor. Her cough assist flows were 225 liters a minute, and she was able to be ventilated comfortably through the upper airway. Her vital capacity increased from 150 to about 500 milliliters, and over the next month, she weaned to sleep ventilation, and then she started sleeping without the ventilator, which is dangerous. So about 8 months later, I was lecturing in California, and she drove up from Santa Barbara, which is near Mexico, to San Francisco to thank me for getting her trach tube out and allowing her to go back to work, also as a teacher, without a trach tube. And that's what she looks like now. A very happy young lady who doesn't have a tube through her neck. So there are 22 centers from 18 countries that have centers for NVS, and they are, these are patients with SMA type 1, many now over 20 years of age on up to CNVS. 6 centers have 101 patients with SMA type 1 who began NVS at 5 months of age, and 14 of them were never hospitalized, even though they became dependent on NIVS. This is to show that topics discussed in neuromuscular clinics in the United States. Respiratory education, 22%. The respiratory clinics in the United States are so bad that even though the great majority of their patients die from respiratory complications, the patients are not trained or even evaluated in the clinics, and respiratory issues are only discussed in 22%. That's how bad things are. And this is the United States. And that's why most of the patients die from respiratory complications. Expert guidelines are terrible. Don't even look at them, because all the patients, they think they end up needing tracheostomy tubes. What are the problems for Russian physicians? Well, first you have to get used to patients becoming dependent on continuous non-invasive ventilatory support. Today, there are over 200 centers in the world that have some patients on CNVS, including patients with SMA, type 1, type 2, Duchenne, and so on. But they only have a few patients in most of the centers. We have 4 to 6 centers with over 50 patients on CNVS. You must also learn how to extubate these patients back to CNVS when they're sick. This is the hard part, because critical care doctors don't want to learn this. It's easier for them to simply put in a tracheostomy tube and let other people worry about the complications and deaths caused by the tracheostomy tubes later on. All patients with adequate cough assist flows, like 200 liters per minute or more, can be decannulated of tracheostomy tubes, and they can be extubated without getting tracheostomy tubes in the first place. Physicians in Quebec are 50 times less likely to even offer NIV to SMA type 1 because they think the patients are unhappy. I have done surveys, and believe me, my patients are satisfied to be alive, and they are not unhappy. This is a website, breathenvs.com, that has a great deal of information for you. Also, my last book was 2004. I have updated the non-respiratory issues in this book. It's available on Amazon, and I would sell it to you for only $20. But the problem is, it costs a fortune to send these books to anywhere. In the United States, it's $3, but to Europe, it's $27. In Russia, I have no idea what it would cost to send a book. I recommend you invite me there one of these years, and I'll bring a bunch of books. Now, in the next 2 months, I'll have the respiratory management book done. The respiratory management book done will be about $50, but it will have a money-back guarantee because none of my patients will ever give it up because it's got chapters on complications of tracheotomies. It has chapters on the expert guidelines and how terrible they are. It has 38 chapters on how to take care of people without sticking invasive airway tubes down their throats and through their necks. I expect to have it done in the next 2 months. And I think that was my last image, so we have some time for questions, I hope. Can you hear me?
Yes, John, we can hear you.
Great.
Так, Елена Юрьевна, мы вас попросим тоже включиться к нам. И мы готовы для вопросов. Мы, наверное, сейчас, Елена Юрьевна, начнем с тех вопросов, которые были у вас.
Можно задавать?
Да.
Во-первых, всем добрый вечер. Джону огромное спасибо за его доклад и за его неинвазивную вентиляцию легких. Мы только учимся на его уроках, на его лекциях, на его книгах. И есть у нас уже опыт декануляции ребенка со спинальной мышечной атрофией 2-летнего и перевод на неинвазивную вентиляцию легких. Вот можно я спрошу про плановую вентиляцию? То есть, когда дети со спинальной мышечной атрофией первого типа находятся на инвазивной вентиляции легких, во-первых, какие все-таки критерии тому, что нужно ребенку начинать? Мы смотрим парадоксальное дыхание, мы смотрим объем грудной клетки, мы смотрим ночную пульсоксиметрию.
All children with SMA type 1 and half the children with type 2 have paradoxical breathing. And you must put them on sleep, non-invasive ventilatory support, or their lungs will not grow. Okay, so all children with SMA type 1 and half the children with type 2 need non-invasive ventilatory support for sleep. They need it 24 hours a day when they're sick also. And the key is, if they get pneumonia and need to be intubated, your critical care doctors, somebody in Moscow or somewhere, must become comfortable extubating them back to non-invasive ventilatory management. If they get trached, they will probably eventually die because of that. Now, I forgot to say something about extubating them. Older children over the age of 4 or 5, they rarely need to be hospitalized because when they get sick, they don't get pneumonia because they cooperate with the MIE. However, and we can extubate them 100% of the time without failing. However, babies with SMA type 1, our extubation success rate is 85 to 90% per extubation because it's difficult to get them in synchrony with the non-invasive ventilation. It's difficult to get them breathing. I'll speak slower. It is difficult when you extubate them to get them to trigger the ventilator. Now, there's something that we have found to be extremely helpful called NAVA, neurally adjusted. Yeah, low system again, right. So I'll just count to 10. NAVA, and NAVA, neurally adjusted ventilatory assistance. NAVA.
John, can you
it's
switch?
bad, but it'll clear.
can you take off the presentation? Probably it will make it better. So if you switch off the presentation. Thank you very much for your time today, and then we will skip this Q&A for now. And we really appreciate your time and your knowledge to share with us. And I think that we will take some Q&A, and if something we cannot address by now with other speakers, we will address you in written if it's possible.
Yes, you have other speakers. Okay, talk to you later. Again.
Yeah, thank you,
okay?
John. Yes,
bye-bye.
Thank you. Bye-bye.
You're welcome. Bye-bye. Bye-bye.
Можете нас вернуть? Да, мы, к сожалению, потеряли профессора Джона Баха из-за сложностей с подключением. У нас очень была прерывистая связь и было невозможно слышать. Поэтому мы, наверное, Елена Юрьевна,
мы вас можем оставить, и мы вот Q&A, который у нас был для Джона Баха, можем провести с Сашей. Я могу показать. Вот, и у нас есть в чате тоже, я вижу несколько вопросов относительно ситуации с конкретными пациентами. Я думаю, что мы их вполне можем здесь обсудить в нашей русскоязычной среде.